And so that takes us to the biopsy and the importance of adequate sampling and the importance of biomarker testing. So Coral, take us through that in terms of a patient undergoes a biopsy. Are you involved at that stage and how do you chaperone, the biomarker piece of it? And what are the considerations that you think about?
Yeah, definitely. Usually when patients come to us, right, is that they already have biopsy proven lung cancer, but most of the times that I'm seeing them at this first instance is basically that's the only thing that I have. So it's starting to trying to like peel off the layers and get the workup going quickly, but understanding that we really need to know the whole picture. So typically what I do is we send them to interventional pulmonologists. They squeeze the patients in very, very quickly within, I think, a day or two that I message them. And then they bring them for the bronchoscopy for not only for like to get a really big sample for the core, but also for mediastinal and hilar staging, because that's something that's very important. Also, sometimes when the patients come to us as a second opinion, that they're offered surgery or that they're offered a little bit of premature treatment without having the really complete picture. So I think this is something that we definitely have the algorithm very well established. And then on the moment that they do the bronchoscopy, then our interventional pulmonologists are the ones that oftentimes send for next generation sequencing, or we order ourselves. It's depend. I think it's been a challenge, at least in our institution, with other physicians other than oncologists placing the orders. I think we've had barriers because they worry that if someone orders them and that's not the physician that's going to follow the testing, that they're worried that they might fall through the cracks. And so unfortunately, sometimes this can lead to delays, but if not, then we make sure that we work very, very closely with those doing the biopsies. Like, listen, this is the case series, and then we put the order right away. And also at that time, while that NGS from the tissue is cooking, we make sure that we also have a blood NGS to at least kind of like have both tests running at the same time. I think it's, again, it's very important, and I would say like completely necessary to really have the whole picture before kind of like moving along and finalizing the treatment plan with the patients.
Yeah, you bring up great points. Thinking though about like early stage patients who are considering for neoadjuvant or perioperative strategies, how does that factor in? For example, if you have a multidisciplinary clinic or if you don't, maybe the surgeon is the first person seeing that patient. Tell me about your take on adequate tissue and then biomarker testing when you see that patient for the first time.
Can I maybe address this? This is something where I think there's a huge burden of responsibility on surgeons to do a better job. I think, it's important for us to recognize that lung cancer resections in the United States are performed by a lot of surgeons who largely do not specialize in thoracic medical oncology. And it's really important to acknowledge that a lot of lung cancer resections are performed by cardiothoracic surgeons who may have a mixed or hybrid practice where they do cardiac and thoracic surgery. There are operations performed by general surgeons. And it's very easy for those of us who have the privilege and the opportunity to work in a very specialized, silo to, I guess, critique others who may jump to surgery or may not know the importance of multidisciplinary evaluation and complete staging and molecular profiling. But these are elements are critically important to our patients having good outcomes. And honestly, for those of us that really do have the luxury of being super specialized and getting to operate on just a couple of disease processes, I really think the burden is on us, the thoracic surgical oncologists, to ensure that everyone who is participating in the resection of lung cancer really helps drive home the point that in this era, in the current year, it is inappropriate to operate on a patient without a diagnosis and without molecular profiling, or at least an opportunity for molecular profiling, just as it would be inappropriate to operate on someone without staging. And so this is something that has been in evolution, and in as much as we would not have wanted to operate on someone 15 years ago who didn't have, appropriate imaging studies for staging. And then it became, why would we ever operate on someone who doesn't have appropriate invasive mediastinal staging? It's very clear that molecular profiling is also part of that. And we are responsible not only for educating our peers, but for educating patients as well, so that patients understand that if they're not being offered the complete picture beforehand, that it's not okay to be taken to the operating room for someone being on a hunt, having a hunch that they might have cancer, and patients can be their own best advocates as well. So I think ultimately surgeons need to be responsible for ensuring that we as a surgical community are doing the right thing for our patients. I don't know, Robert, what are your feelings on that?
No, Mara, I agree with you completely. I think in 2025, I think getting biomarker testing should be a standard of care, just like, mediastinal staging, appropriate imaging studies, preoperative testing for cardiopulmonary fitness. That should be on the checklist of things that should be done prior to any operation or for lung cancer in 2025. And I agree that, it's on the academic thoracic surgeons who work at cancer centers and academic centers to educate, our peers that this should be the standard and that we should make every effort to get biomarker testing. It also includes pulmonologists who perform navigation bronchoscopies and radiologists that perform CT guided biopsies that, the biomarker testing should be top of mind, and they should do additional biopsies to make sure they have enough material to do NGS and PDL1 testing.
Good point. And I think it's really important, especially thinking about early stage and resectable non-small cell lung cancer, as we think about the perioperative strategies or neoadjuvant strategies, because in my mind, it would influence, the decision of what strategy to use in the preoperative setting. You want to make sure that if a patient has an actionable driver mutation, that perhaps that patient may not be best suited for a perioperative strategy with immunotherapy. And one thing that has helped in our institution was to integrate NGS requests within our EMR. It made it easier that anybody in our multi-D team could actually order the test. It's a few additional clicks, and the results come to everyone. It's in the chart in a specific point. And it really has helped for us to plan perioperative strategies, independent of even clinical trials, just standard of care, testing that we do. Has that been something that has changed as we have all the new data that we'll be reviewing today? These factors of not only biomarker profiles, PDL1, as you were stating, would that influence your choice between neoadjuvant and perioperative strategies?
Yeah, so I'll just comment and then Dr. Antonoff can comment. At our institution, if someone has a actionable driver mutation, EGFR, ALK, and they, qualify for adjuvant therapy, we probably would opt for, the, ADORA trial or the ALINA trial. If they have high PDL1 expression, then we may opt for either neoadjuvant immunotherapy or perioperative immunotherapy. So the biomarker testing does really drive our decision making.